Welcome back after lunch. It's a risky time to talk because usually they have a postprandial somnolescence so I'll try and keep you awake. Um, we'll try and finish the talk and the next session sharply around 4 because we'll have our remote speakers joining it from the US. So we don't want to keep them waiting. Dr. Manoj requested me to talk something basic. Colon cancer, as you know, giving a talk can go different ways. It's an area that has a lot of molecular data that we can talk about. But the request specifically was something that the junior members in the audience, trainees, and junior faculty may find helpful. And so if you don't like and you find this too basic, you can blame Dr. Manoj, not me. So what I'm going to do and try and do it quickly is focus on a few key aspects, most of them revolving around how do you fill out your synoptic template if you use the CAP reporting guidelines and you use the current standard of care, what is important even before histology. So just like the stomach cancer story, colon cancer management also revolves heavily around us as pathologists. So if you get a colon polyp or a polypectomy specimen with cancer, the clinical issue at stake is, does this patient need completion colectomy or is this curative? And if you get a resection for colon cancer, the key clinical question is, does this patient need additional therapy, either more resection for positive margins or chemotherapy because you have positive nodes? So essentially, everything we do revolves around those two key questions. So diagnosis of colorectal cancer, again, that's a morphological differential diagnosis that's very important. Causal misplacement, we are not going to talk about it today. We are going to focus mostly around staging colorectal cancer in resection specimens, and I'm not going to talk about screening for Lynch because that will be the next panel discussion section. So this is going to be pretty much the outline. Talk a little bit about malignant polyps, just so you know that we covered it, and then focus the rest of the talk on staging. So there are a few key features, just like in endoscopic resections of gastric cancer. As a general rule, the deeper the invasion of adenocarcinoma, the more likely it is to spread to nodes. Roger Haggett, by whose name the US GI Path Society runs, was the first to identify this fact that if you have pedunculated polyps, meaning polyps with a stalk, the risk of nodal disease really increases as you go from the head of the polyp to the head of the stalk to the native submucosa. So these go by Haggett level, and the risk of nodal disease doesn't really increase significantly until you're down to level 4. Of course, the Haggett levels don't really apply when the polyps are flat or sessile because they don't have a stalk. And so different criteria are used, but basically the same principles. So depth of invasion is important. And if you have a endoscopic resection of a flat polyp, then depth of invasion more than 1,000 microns is a high risk feature. So depth of invasion, rate of differentiation of the tumor, presence or absence of lymphovascular invasion, distance from the margin, the deep margin, and tumor budding are the features that we look for when we are trying to decide, is this a curative polypectomy or is this patient requiring completion colectomy? The SM2, 1, 2, 3 criteria, the submucosal invasion 1, 2, 3 are heavily used in Japan and also many parts of Asia. The challenge with them is that when you get endoscopic resections, you don't really have the muscularis propria. So the SM1, 2, 3 basically refers to divisions between the submucosa and the muscularis propria. So you arbitrarily roughly divide it into thirds and then say whether the depth of invasion is SM1 or 2 or 3. But because in endoscopic resections, you don't really have propria, you don't know what that thickness is. So you don't really know what SM1 is and what SM2 is. And hence this shift to not report things as SM1, 2, or 3, but actual depth of invasion, which you can measure from the muscularis mucosa, and then give your clinicians information that they really need to decide what to do next. So this is kind of the basic report that will look like if you have a malignant polyp with cancer. If it's pedunculated, give a Haggett level. If you have a sessile polyp, you have a choice. You can give SM levels if you feel comfortable, or more accurately, give the depth of invasion, tumor grade, lymphovascular invasion, tumor close to the margin, meaning less than 1 millimeter from the margin, and then high tumor budding. The difference, so when you stage colon cancers, budding is divided into 3, low, intermediate, and high. And so for polypectomy questions, the high tumor budding is not more than 10, it's more than 5. So remember that. So all these features kind of decide whether a patient needs. Obviously, this is not the only thing. We don't decide what to do with the patient based on just histology, like we were discussing in the IBD talk. You need to know what the patient demographic is, what the patient's age is. If it's an 85-year-old man with multiple comorbidities and you have one feature that's high risk, you're not going to do a colectomy in that patient. So it requires, again, a team approach to deciding what's best for the patient. So this was some changes that were made in the 7th edition, which have stayed put in the 8th. T4 was divided into A and B, which we still use in the 8th edition. The nodal stages were subdivided. One change that was made in the 7th edition, which was a source of a lot of confusion, was tumor deposits. And we'll talk about what we are trying to do when we say tumor deposit. And then the M stage was also divided into A and B, depending on number of sites involved. So let's start with the basic depth of invasion. So the PT stage is the deepest invasion of the cancer in the colonic wall. And of course, if you have perforation of the visceral peritoneum, that's a T4A cancer, but it's easier said than done. Some cases will be simple, straightforward. Some may be challenging. The definitions and how we apply them have changed over a period of time, and we'll go through those in a minute. T4B is relatively easier to diagnose, so we won't spend too much time talking about it. I want to emphasize just 2 things. One, contiguous spread through the wall is not T4B. So if you have a cecal cancer that's spreading into the ileum by way of muscularis propria, that's not T4B. To call something T4B, the tumor has to perforate the peritoneum and then involve an adjacent organ. Only then will it have the adverse prognostic significance that we associate with T4B. So think of a sigmoid tumor going through the peritoneum and then adherent to the ovary or the bladder or the uterus. That's a T4B. If it has a contiguous mural spread, cecum going to the appendix, cecum going to the ileum, that's not T4B. And then you can have clinical T4B, but not a pathologic T4B. So you can have bowel loops adherent to each other, or a bowel loop adherent to the bladder or uterus. That's a clinical T4B. But when you take sections and it's an inflammatory adhesion, you don't find actual tumor in it, then it's not a pathological T4B. So you still stage it as a PT3, and it's a clinical T4B. So just remember that those 2 things are important when trying to decide T4B versus T3. All right, so as I said, some T4As are simple. You have a colon, that tumor that's perforated. It's you don't need a slide to stage this as a T4A. It's gone through the peritoneum. Something like this, a transverse colon cancer adherent to the abdominal wall, you don't really need slides to say that, yes, you cut through the specimen, you can see tumor going into the skin. It's a T4B. The challenge is when you have an inflammatory and fibrotic response at the advancing edge of the tumor, and then deciding what's actually breached the peritoneum and what's still within the peritoneal confines can be challenging. So Neil Shepard, a good friend of ours in the UK, came up with this idea many years ago and tried to subdivide depth of invasion of tumors close to the peritoneum into 4 groups. Group 1, which was well clear of the peritoneal surface, 2 that was close but not actually involving the peritoneum, and then 3 and 4 were basically what we now call T4A. So the current definitions say that the tumor should be at or on the peritoneum. And it's a little silly, but I'll tell you what they actually mean. So at the peritoneum would be something like this, where you have tumor really sitting on the mesothelial surface. And then on would mean that it has breached and you can find tumor cells really floating in the peritoneal space. And then the others, 1 and 2, would be where your peritoneal surface is here and the tumor cells are here. There's a fibrotic inflammatory response, but the tumor is really far away. So this is another good example of tumor at the serosal surface. This is a consult case. We never ink the serosa. You should not ink the serosa, only ink true, real margins of resection. And we'll come to what an actual margin is in colon cancer resection. And then this is a good example of tumor perforating through. Whenever you have a colon cancer that's either close or perforating or about to perforate, you will always see a reactive mesothelial proliferation, a lot of hemorrhage and inflammation. So this is not tumor, this is reactive mesothelium. So what looks like tumor, this papillary proliferation here, is all reactive mesothelium because the tumor is actually going through and seeding the peritoneum. So those are clues that if you see mesothelial reaction and the tumor looks far away, you should worry that there is some perforation or some breach close by. So either take more sections, cut deeper levels into the same block, because you're more likely than not, you're going to find a T4A. One thing that's relatively under-recognized is that you can have a T4A in the rectum. When we come to mesorectal coverings, we'll talk about peritoneal coverings on the rectum, but remember that in the upper part of the rectum, the anterior surface is completely covered by peritoneum. And so you can have a T4A even in the rectum. The rest of it is soft tissue margin. So you can have a T3 or a T4B, but not a T4A because there's no peritoneum. And it's been shown in many nice studies, including this one, that it's a good marker of local recurrence, not of systemic recurrence, but breach of the peritoneum predicts pelvic recurrence down the road. So it's an important prognostic factor for us to recognize. So the first thing to do, as most of my mentors used to say, emphasize grossing and say garbage in, garbage out. So the key thing for you to do is make sure you're sampling the specimen from the right place. If you don't do that, there's nothing you can do on the slide, and I'll show you some good examples that's going to fix that error. So the first thing is how to recognize breach of the peritoneum, that this is a tumor on gross that looks like it should be a T4A. And there are a few key features you can see. So one is this puckering. So you can see this whitish area here. This is the smooth surface is all serosa. You can see this puckered or pulled in appearance. So this is very helpful in saying this should be a T4A. Kinking of the bowel. So you can see the serosa again puckered in or pulled inside. It looks almost like a stricture. That's very suggestive of a T4A. And this is rectum. Again, you can see the same dimple on the serosa. So this is all peritoneal covering. And identifying these areas in mucinous carcinomas, you can see little droplets of mucin on the serosa. That's very helpful. So any abnormality on the surface that makes you think that this could be a T4A is where you have to sample. And we use this, I've used this for more than a decade now to train our first year residents and pathology assistants who help with grossing. So this is obviously, you can see a serial section of a colon mass. And the question that I ask them is, which is the slice that you would put through for microscopy to decide the greatest depth of invasion? And because we have this idea in our head that the depth of invasion goes through mucosa, submucosa, propria, perimuscular connective tissue or fat, and then serosa, most of the trainees initially at least will pick this slice and say, well, this looks like it's invading the fat, which is true, but you have to remember that not all parts of the colon, it's not a circumferential fat pad all around the colon. So because the colon outer longitudinal muscle layer comes together in 3 broad bands, the tinea, the entire circumference is not surrounded by fat. So there are parts of the colon where the difference between a T3 and a T4A is literally a few millimeters. So if you have tumor going through, into pericolonic fat, that's a T3. So if you put this section through for your staging purposes, the final diagnosis will read a T3, as opposed to the fact that you put through a section here. It's going through the muscularis propria and it's breaching the, you don't need a slide, you know that it's gone through. So this is the T4A. So there's no way around sampling accurately in a colectomy specimens for depth of invasion. So remember that the deepest extent of invasion may not be through fat, it could be directly through the parts of the muscularis propria that are not surrounded by subserosal adipose tissue, and that's going to be your deepest invasion. The other thing to remember, which again, if you look at the AJCC diagrams, they're pretty annoying because they show things very linearly. So if you look at the diagram of mucosa, submucosa, propria, and serosa, they're all straight horizontal lines. The peritoneum doesn't exist as horizontal lines. It follows the contours of the bowel and the organs. And so crevices are very important. So all these enfoldings that you can see here. So this is subserosal adipose tissue, and part of the colon where there's no subserosal adipose tissue, there's obviously an interface, and they usually are these narrow triangular slit-like spaces that go in. And more often than not, you will have a deeply invasive tumor that's going to breach these little grooves or crevices. So if you sample the colectomy specimen and you take a section from here, what stage that's going to be? It's going to be a T3 because what you'll document is tumor going through subserosal adipose tissue, because you left out the more important area, which will help you diagnose it as a T4A. So here is the corresponding section just to demonstrate that fact that if that was your gross, this is your microscopy counterpart, a section going through here, you will never know what was in that little crevice, and you will stage it as a T3, whereas it actually was a T4A, which you can see tumor here at the peritoneal surface. So very important to make sure, one, look at areas that are very likely to have serosal perforation and growth, and two, never forget the crevices. And it's an important pitfall. Every week we end up upstaging cases that were called T3 outside that are actually T4As. And why is that? Because, as I said, the peritoneum goes into these little crevices, and in advancing tumors will sometimes breach, and then there'll be a fibrotic response, so they will be sealed, and there'll be little pockets of mesothelium within the tumor that you can identify, and you know that this was a T4A that has basically sealed off after perforation. So remember that I said the serosa doesn't exist as a linear line, and this is what I mean, that sometimes the tumors can look actually far away from the peritoneal surface, but because these crevices go in very deep all along the crevices, the peritoneum is actually not far away from the tumor. So you can see here the adipocytic lobules that surround the colon and these penetrating little crevices that are all mesothelial lined. And if you do your mesothelial markers, you can actually demonstrate that this is mesothelium going in deep into the subserosal adipose tissue. So why is that important? It's important because in cases like this, you can see this is a consult where there were marks made on the slide. At a cursory look, this will look that this is T3 because this is tumor going into subserosal adipose tissue. But if you look a little more carefully, you'll see these little crevices and clefts going in that I was pointing out in the previous slide. So this is one cleft or one groove. Here's another cleft or another groove, and here is another one going in. So I'll show you a high part just to convince you that this is actually tumor at the peritoneum, even though it looks that it's far away. And it looks far away only if you have that linear concept in your mind. So the same hemorrhagic inflammatory response that I was talking about, you can see here. And if you're in doubt, you can actually demonstrate. If you have colleagues who are not convinced, you don't have to argue. You can do an immunostain and actually prove that you're right. So you can do WT1, calretin, whatever your favorite mesothelial marker is, and actually show that this is tumor sitting in the peritoneum and it's outside, not in fat. So the adipose tissue can be actually a little misleading. There was some interest. I'm just going to talk about it quickly just so that you know what the controversy or the discussion in literature is around elastic lamina invasion. There was a time some years ago where there was a lot of interest in using elastic lamina invasion to identify T4A tumors. We still don't do it. The data is still not convincing enough to switch from our routine H&E diagnosis. But the basic idea was that like all serosal surfaces, whether it's pleura, pericardium, the abdominal peritoneum also has a delicate lining of elastin underneath the mesothelium. And just like in lung, where you can use elastin stains to say whether the visceral pleura is breached or not, you can do the same thing in colon. And there were some very nice studies done initially in Japan and also in the US and in Europe, showing that tumors that look far away from the peritoneal surface are actually not that far and or may have actually breached the peritoneum because of the phenomena that I was talking about, that when tumors invade, they have a desmoplastic stromal response around them. And if they breach the peritoneum, you'll see the same desmoplastic stromal response. And sometimes that will actually seal off the tumor from perforation. So there were two kind of arguments going back and forth. One was that, oh, this is tumor that has breached the peritoneum, so why not call it a T4A? And the counter argument was, well, it's incited a desmoplastic response, so it's actually holding the tumor back. So why do we want to call it the same way as T4A without a desmoplastic response? And so we have stuck to the H&E definition. We don't use elastic lamina, but just to show what people were talking about. So this is a tumor that looks at, it has nothing to do with the peritoneum. You do an elastin stain, you can see that it's actually sitting right at the elastic lamina of the peritoneum, but it has a lot of fibroinflammatory response that makes it look spuriously as if it's far away. Same thing here. This is again a tumor, the peritoneum. You can see this black ink again here, which looks as if it's far away. And here you can actually see tumor on both sides. So this delicate black rim is the elastic lamina, and you can see tumor on both sides of it. So this is breach of elastic lamina or elastic lamina invasion. And you can see that if you have the LPI refers to the Neil Shepard group 1, 2, 3, 4 that I showed you, that even group 2 tumors that seem very far away, if you do elastin stain, you can see in roughly half of them evidence that the elastic lamina has actually been breached. And it seems that, at least in those early studies, that this may be of prognostic significance in predicting peritoneal recurrence, if not systemic recurrence. And also in the same studies showing that cases that are called T3 by conventional criteria, but have elastic lamina invasion, tend to do worse compared to those that don't have any elastic lamina invasion. And if you look at overall survival, cases that were T3 with elastic lamina invasion tend to behave similar to PT4 or T4A conventional criteria cases. And the challenge has been that it's a very delicate structure. The elastic lamina is very thin, almost like the elastic lamina in a vein. So if you're using elastin stains to pick up vascular invasion, that's challenging. The same thing holds true for peritoneal lamina. When it's so delicate and completely breached, there is no way for you to actually detect. So in many cases, you don't see any black staining of the elastic lamina. And then the studies that were done to explore this concept over a decade showed contradictory findings. So the current AJCC CAP guidelines don't require you to do elastin stains to stage PT4. Moving on to lymph nodes, again, there's a lot of literature showing that the number of positive nodes is of prognostic significance. It's the biggest triage in colon cancer resection. Patients who are node positive get chemotherapy. There are some modifications to that paradigm, largely based around MSI high cancers. We won't go into them. But node negative versus node positive is a huge deal in colon cancer. So you want to get that right. The number of positive nodes are of prognostic significance, but they don't change therapy. So yes, you want to do an accurate job there, but the most important thing is making sure you're not missing a positive lymph node. And the QA criteria that have evolved in the US basically say that somewhere between 12 to 15 lymph nodes is what you require to adequately stage a colectomy. Because it was shown in early studies that the colectomy specimens that had less than 12 nodes examined those patients tend to do poorly, and they tended to do poorly because they were not properly staged. So it's nothing to do with the tumor, it has to do with pathologic examination of the colectomy. And then you can see nicely that the node positive ones can be stratified into N1 and N2, and that has prognostic significance. Obviously, it's an indirect measure of tumor burden. The more positive lymph nodes you have, the poorer the prognosis is going to be. So the number of lymph nodes is important. The QA criteria that we currently use make very little sense, and I'll tell you why. And that holds true. The number of nodes examined in a colectomy is important, not just for stage 2 node negative ones, but also for stage 3 tumors, which you can see in this study, where the greater the number of lymph nodes, the better the outcome. And that's because we are appropriately staging the colectomies in those patients. So we know from experience that the number of lymph nodes that you enter as the denominator in your synoptic reports depends on a lot of things. What time of the day you were doing the grossing examination, how tired you were, how many other colectomies you had to gross that day, did you have a Whipple to gross the same day along with it, and so on and so forth. So the diligence, it's a manual, tedious task, so it takes time to do it well. Obviously depends on tumor characteristics. If you have a colectomy that you find very easy to find lymph nodes and you found 50 the first time around, I can guarantee those are all going to be negative because that's an MSI high tumor. So microsatellite unstable tumors, remember the lymphoid infiltration I was showing you in the gastric cancer, the same thing holds true in colon. MSI high tumors have very large, bulky, juicy lymph nodes, which are very easy to identify. Your counts will be very high, but they're all going to be negative. So the hard part is finding those small 5 millimeter or less in size lymph nodes, because those are where you're going to find the positive ones. Surgical technique, obviously, if you have a bad surgeon who didn't do a good job clearing out the lymph node basin. Patient variation, you may have an asthmatic or somebody who's on steroids, the lymph node becomes small, harder to find. Post-neoadjuvant chemotherapy will shrink those nodes down, so it requires a lot of effort to find lymph nodes. And then obviously the anti-tumor immune response, which I said is going to make it easy, but it's not going to be helpful in finding the positive nodes. So there were some studies done looking at whether fat clearing agents can help, because colectomies have a lot of pericolonic adipose tissue, so it's hard to find lymph nodes. So they showed that if you use fat clearing agents, obviously the yield of number of lymph nodes that you see goes up. The important thing to remember from this study is that 75% of all positive nodes were actually small ones. So you cannot use size and sample the large ones preferentially, thinking they are going to be likely the positive ones. Actually, the small nodes are going to be more likely to be positive. So why did I say that the number of lymph nodes examined is a bad QA criteria? And it's a bad QA criteria because you can see that since the late 80s, really in the 90s, we started pushing this QA criteria that if you are not examining at least 12 lymph nodes, you are doing a bad job. And that's true because it's a surrogate marker. The denominator of lymph nodes is a good surrogate marker of the quality of examination. But you can see that this green line represents the number of colectomies in the US in which more than 12 lymph nodes are found. And you can see this very dramatic rise from kind of the mid 1990s to around 2010. But look at what happened to the number of cases staged as stage 3 or node positive cancers. That remained almost flat. So you would expect this curve to be budging upward. It's not obviously going to track the same way, but there should be an upward trend, which is missing because the QA criteria makes very little sense. And this is another study looking at the same thing, this one from Europe, that you can look at the number of cases in which 12 or more lymph nodes were examined, kind of gradually increasing over time. But the number of cases staged as node negative is essentially flat, no change whatsoever. And so why is that? It's because where you sample those lymph nodes from is also important, right? So you want to sample preferentially and thoroughly from around the tumor, because that's where the first lymph node metastasis is going to be, right? So it's intuitive. So the denominator doesn't really tell you where those lymph nodes were from. So Imagine two scenarios, one in which you have 5 lymph nodes in these 3 stations, and another in which there are 11 from the peritumoral zone and 2 from far away. Your report will say 0 or whatever out of 15. This is a thoroughly understaged colectomy specimen. In my opinion, this is also thoroughly understaged because it's not hard to find 30 plus lymph nodes in a colectomy specimen, but at least you have a better job looking at tumors in and around the tumor. And we've tested this many times in many different institutions, and it holds true. So many years ago, this was the first trial looking at a consecutive series of colectomy specimens where we arbitrarily divided the tumor basin for lymph nodes into primary and secondary, and that 5 centimeter was just an arbitrary number to come up with, where we said we look at lymph nodes separately in and around the tumor and those that are far away and see what happens. The second thing we did is that we are not going to sign out anything as N0 without having a second look at whatever fat was left behind, because that's the perfect QA measure that you can do. Because of the reasons that I first said, it's a tedious job. You could be tired. The PA could have been tired, and you don't put through every single lymph node the first time. And I've had this practice for almost 15 years now where I don't sign out anything. You give me 50 lymph nodes the first time, I'll still ask the PS to go back and they dislike you. But then they have a conversion. I've had conversions at every level you can think of, at 15, at 25, at 35, at 45. And so it takes time to make them into believers. But once they buy in and they see a case converting from N0 to N plus, that practice stays. So this is standard practice at our place, where we don't sign out anything as N0. If you do a second search in every case that's N0 at first attempt at looking at lymph nodes, you'll find on average about 10 lymph nodes in the second search, about 6 or 7 in the primary basin, and about 4 or 5 in the secondary basin. And more importantly, what you end up doing is you end up staging roughly 4 to 5% of node negative cancers. And this has held true at every place I've ever worked. It held true at Dartmouth, it held true at Brigham, it holds true at Memorial. And it's not always going to be one lymph node. You can have conversion from N0 to N2 for the reasons that I discussed, that it's a tedious job and it's easy to make that mistake. And most of the metastases are going to be in small lymph nodes that are more likely to be missed in your search. So be as thorough as possible. Don't hesitate to go back. It's not a criticism. It's not a critique of the person who did the first. Actually, we have a protocol where the second search is done by a different person. If there was a resident who did it, there's a PA who's going to do the second search. If it's a PA who did the first search, we'll have a resident go back and do the second search. And the idea is to have it's no different from having your colleague look at a slide and say, hey, what do you think is the diagnosis? So it's the same kind of concept, that you want another pair of eyes looking at the same thing, trying to figure out, did I miss something? All right, what about tumor deposit? This is something that has created a lot of problem in everybody's mind, and it has gone through different iterations. In the 5th edition, it was size criteria, 3 millimeter or more, or versus less. In the 6th edition, it was a contour, meaning that if it's a rounded deposit, call it a lymph node. If it's irregular, call it vascular invasion. And then in the 7th edition, we came up with this N1C categorization. So the basic idea or the challenge is that what to do with a chunk of tumor sitting in fat with no direct extension or connection with the tumor up in the wall. And of course, if you have something like this, it could be venous invasion, it could be lymph node invasion. So when you're lucky and you find a delicate rind of lymph node tissue, it's easy. You can say, yes, it's all necrotic, but there's a rim of lymphoid tissue, so I'll count this as a positive node. When you don't have any lymphoid tissue and you don't have any other structure left, it's hard to know whether this was a vessel to begin with or this was a node to begin with. And that's the challenge that created this concept of a tumor deposit. So when you're lucky, you can see some remnants. Here, there's a wall of a vein left and a little bit of lumen. Here, there's a little bit of lymph node left. The contour rule never made sense because you can have tumor in a lymph node that breaches through, so it's irregular in outline. Tumor in a vessel can be perfectly round, so just using shape doesn't really make sense to decide whether it's node or vessel or something else. So there were two things that we wanted to be careful about. One, there should be no connection to the tumor up in the wall. So it's a T1 or T2 tumor or even a T3 tumor, but what you're looking at is far away from the main tumor mass. If it's hooked up, you use it in the T stage for depth of invasion. You don't use tumor deposit. The second important thing is if you already have positive nodes, you don't use N1C. So if there were two conventional positive lymph nodes, you use those for staging. You mentioned tumor deposits in your report, but they don't qualify for the N1C designation. So why did we come up with this separate categorization? The challenge was that most oncologists use the nodal status to decide which patients need chemotherapy. Extramural venous invasion is a known prognostic factor that predicts distant metastasis. And in the current guidelines is one of the features. If you have node-negative cancers, there are some indications on histology that qualify patients for adjuvant chemotherapy despite the nodes being negative. One of them is T4A, which is why we are spending so much time on those parameters so that you get them right. And the second one is extramural venous invasion, because it predicts, not surprisingly, you have a large vein sitting in pericolonic adipose tissue. Those tumors are more likely to go to the liver or to the lung. So that's an indication for adjuvant chemotherapy. The challenge was that most oncologists were not using it as a parameter to recommend adjuvant chemo in node-negative patients. And so to get around that, we created this nodal staging to put tumors in the N category so that patients could get the right treatment. But it has been a circle because, I mean, we know it's either it's extramural venous invasion, but we are putting it in the nodal category and calling it N1C. Quick words about radial margin again, because we go back to the grossing issue. Remember that we think of colon as one thing, but in terms of peritoneal coverings, they are very different. So the cecum, transverse colon, sigmoid colon, they're all intraperitoneal. They hang freely by a mesentery. So the only true margin in those resections will be the mesenteric margin. If you read the synoptic template, it's confusing, and we struggle with our trainees all the time trying to help them determine what's a mesenteric margin and what's a radial margin. So anything that a surgeon has to cut through to get the colon specimen out is a radial margin. So in cecum, transverse colon, sigmoid colon, the only thing they have to cut through is the root of the mesentery. So that's your only radial margin. So radial and mesenteric are the same at those three sites. In the right and left colon, the anterior and lateral parts are covered with peritoneum. So this whole blue on either side is peritoneal covering. And then the posterior aspect sits right against the retroperitoneal soft tissue. So the posterior part is a true radial margin. So if those of you who have done autopsies have seen, you know, when you drag the colon out and you rip the colon out from the abdominal cavity, that's a radial margin. You're freeing the colon up from the attachment to the colon, to the retroperitoneum. So in right and left colon, there'll obviously be a mesentery because they have to cut through the mesentery, but there'll also be a true posterior radial resection margin. The reason we get away with not doing a good job is that that's seldom going to be positive, because if it were positive, the surgeon is not going to cut through it. You may see it in palliative cases where, you know, it's being done because the colon is about to perforate or is obstructed completely, so they're taking it out, but the surgeon will know it's a positive radial margin, so you don't really have to tell them. But that's also in circumferential tumors in the right and left colon. Pay attention to the posterior margin too, because that could be positive. If it's positive, those sites will get additional radiation therapy, so it has clinical significance. And that's how a circumferential radial margin, remember the picture that Atur Singhi was showing of the uncinate margin, the ragged, rough surface, the same thing holds true here. So this is the shiny, glistening surface here is all peritoneum, and you can see this transition from this smooth, glistening surface to a more raw, ragged, soft tissue. Usually there'll be little threads here because they have to tie off bleeding vessels. So that's your true radial resection margin here. Sometimes you'll see a positive radial margin because there was a positive lymph node close to the radial margin and the tumor breaches through. the implications are not quite the same as a positive radial margin with the actual tumor going through, because there's not much the surgeon could have done about this scenario. So just to show you some examples, this is a sigmoid colon resection, again, for the trainees. The glistening, shiny surface here is all peritoneum. So don't ink this, because once you have a section separating the peritoneum here from the true radial resection margin is going to be very challenging. So don't ink anything that's not a real resection margin. So only ink this area here, which you can see this rough surface with ties that are bleeders, and that represents your true radial resection margin. Rectum, as I said, we'll come to it in towards the end of the talk. So remember the rectum on the anterior surface, the upper half is covered with peritoneum. So you can see this nice shiny peritoneal covering going up. So that's the posterior aspect. The posterior aspect is all true radial soft tissue resection margin. So here, what you have to ink is the posterior aspect and only this aspect here on the anterior surface and the lateral side, because that's your only true radial resection margin. So you can get a T4A here, but not here, because there is no peritoneum. So you can get a T4B, as I said earlier, but you cannot get a T4A. So even knowing where the tumor is location-wise, whether it's below the peritoneal reflection or above the peritoneal reflection, will tell you what's the maximum T stage that you can expect in your specimen. It's also important to know, because high rectal tumors that are much above the anterior peritoneal reflection can be treated almost like sigmoid colectomies. Vascular invasion, similar to the elastic lamina invasion issue. Again, if you have a T4A tumor, you don't have to be very particular. Even if you miss extramural venous invasion, it's okay, because it's already high risk. If you have node positive tumor, it's okay. In patients who don't have any high risk feature, doing whatever you can to make sure you're not missing extramural venous invasion is very important, because as I said, that's the whole idea. It's a high risk feature, and those patients should get adjuvant chemotherapy. Finally, tumor budding is something new. It's an optional criteria, not mandatory. Recommended in malignant polypectomy specimens, not in colectomy specimens. I just put it here just for completion. Essentially, the idea is that if you have, it's a risk factor for local and distant metastasis. The idea behind it is that gland-forming tumors, a subset of them, at the advancing edge will give off these little clusters of tumor cells, and that's a high-risk feature. It's part of the epithelial mesenchymal transition. And if you do your keratin stains, you can actually highlight those buds very nicely. So that increases the risk of nodal disease, and hence it's an important feature to report, but again, optional at the current time. Tumor budding is recommended in polypectomy specimens because it's a very robust predictor of lymph node metastasis. As I said at the beginning of the talk, the threshold that we use is slightly different. It's not more than 10, it's more than 5. So if you have cases like that and your surgeons follow the guidelines, they will often ask you, what is the tumor budding? If you don't have LVI, it's not polio differentiated, it's far away from the margin, high tumor budding might tip them into doing a colectomy, especially in young patients. Finally, post-neoadjuvant resections, we won't spend too much time. Often the tumor has shrunk, it regressed, so all that's left is a scar. You may not actually see much of the tumor, but essentially you have to block out that entire tumor site to make sure you're not missing tumor. There's many grading schemes for post-neoadjuvant specimens, depending on how much tumor is left. This was one of the first. What's used currently is the current CAP criteria, where you have grade 0 to grade 3, depending on the amount of residual tumor left. One important thing is acellular mucin pools don't change what needs to be done to the patient. So you count them as tumor response. If you have acellular mucin at a margin, it has no prognostic significance. If you have acellular mucin in a lymph node in a post-treatment setting, don't count it as a positive node. That qualifies as treatment response because you cannot get rid of the mucin. So if all there is left is acellular mucin with no tumor cells, it will be a YPT0. And then finally, there's something in your template about rectal resections. If you get total mesorectal resections, the quality of the mesorectal fascia is very important because it changes the risk of recurrence from less than 10% to actually 30%. And how you report this is these three categories: complete, near complete, and incomplete. And essentially what that means is how good the surgeon was in taking the rectum out. So complete would be the whole surface has this smooth fascial covering around the fat. Near complete would be where mostly fine, but you start seeing little holes. And incomplete meaning that you are seeing parts of the muscularis propria. So is the clearance of the rectal nerve plexus and lymph nodes was not done nicely, and that's a risk factor for recurrence. Final slide, just to show the holy grail of colon cancer staging, which we still don't have a good answer. Part of the answers were in the talk that I gave you, and the holy grail is that if you look at outcomes, both in the 6th and the 7th editions, there is this paradox that the stage 3A patients, the outcome is actually better than stage 2B. And the reason that happens is that there is a subset of 2B patients, the so-called node negative patients, that are actually not node negative. So they don't get the chemotherapy that they need, and that drives the outcomes. So about 20% of stage 2 node negative patients will relapse on follow-up. Many of them will be because it was T4A, understage as T3. Many of them will be because they were node positive, but were called node negative. And hence, everything starts with the first-year residents and the trainees who are grossing the specimen. And if you don't do a good job, there's not going to be a good diagnosis at our end. Thank you so much for your attention.
Nice presentation, and it's wonderful coverage of the topic, and both colon and rectum you nicely covered on pathological aspect. Any questions from the floor?
Yes.
Regarding the extramural muscular invasion, are you doing any staging, or outer arterial side is good enough?
Again, depends on what else is there in the specimen. So if we, as I said, if you have a patient that's a T3 nodes negative, then yes, we'll do elastin stains to try and pick up extramural venous invasion that we did not see on H&E. If you have something that's classic where you can see the lumen, there's part of the wall that still remains, we don't really do the stains. We just call it extramural venous invasion. So what Dr. Das is referring to is this so-called orphan artery sign or isolated artery sign, which means that in the colon, the arteries and veins travel together. So if you have a large artery and you don't see the adjoining large vein, that means that there must have been some breach by the tumor. And to pick them up, to highlight them, you can do the elastin stains, but it's the same thing as the peritoneum, that the lamina is so delicate that if you're not sure on H&E and you do the stain, it's seldom helpful because the lamina is disrupted and gone and it's replaced by fibrosis. So it's the elastin stain can be helpful, but it's helpful in cases where I didn't really have a doubt on the H&E. So
you can ask. Bandana.
We actually follow first 5 sections, then we take a read, and then if it is not showing any tumor, we cut it to 3 different levels from the top. Is that adequate, or
now, if you did that, we would sign out 1 colon cancer a day. So we don't level. So if you don't see, if you have blocked out the whole tumor bed, we don't level to find, because at that point, you are basically trying to distinguish 0 and 1. And that distinction is not really that important. In post-neoadjuvant setting, the most important prognostic parameter is positive lymph nodes. The tumor bed response is not going to predict either need for additional therapy or prognosis. They really know right now, they have a very good sense. We were talking about neoadjuvant resections at lunch. If they see a very good response or a near complete response, they don't even operate now because they just keep the patient under surveillance till the tumor starts growing, because surgery doesn't really add much in patients who have a great response to chemotherapy. So if you know the rectal cancer story in Lynch patients, where basically they are cured by immunotherapy, those patients don't get their rectum out, and that's the whole idea. So trying to separate, I mean, yes, as pathologists, we want to to do things that we like to do and grade and stage. But in terms of practical importance and clinical significance, separating 0 from 1 to 2 to 3 to 4 and then 5 is not really necessary.
Dr. Srivastava, I have one question.
Sure.
What is the role of ISC in pathology assessment of a pathologist while making a correct diagnosis of CA rectum or CA colon?
Not so much in diagnosis of carcinoma. I mean, we can talk about pseudo invasion versus true invasion, maybe presence or absence of LVI, but nothing really in the actual diagnosis of cancer. That's really a bread and butter H&E diagnosis. In terms of management, yes. I mean, the next session is going to be about MMR, and that's like the huge chunk.
Obviously, they are going to have a discussion on Lynch syndrome, so that part would be
Yeah,
discussed. I have one more question from surgeon's perspective.
Sure.
How many minimum section and how millimeter thick section should be for a pathologist to have a perfect, I mean, histopathological assessment and tumor site?
You mean when you're doing a biopsy for the first
Yes,
diagnosis?
sectioning, yeah, micro sectioning.
That's usually I mean, we always say the adequate specimen is one that helps you make the diagnosis, right? So there are no guidelines, and it's hard because if you have a big bulky mass, you may be nibbling at the surface and you may get the adenoma precursor, not the cancer. Surgeons, gastroenterologists always want us to make the diagnosis the first time because the management can then proceed according to the diagnosis. So in general, I think trying to focus on the attachment to the wall and trying to get as deep a biopsy, getting a bit of the submucosa as possible is going to help you. Not going around the head of the polyp or the circumference, because that's where most of the precursor is going to be. So again, the polyp stalk where it joins to the wall of the colon, or where you can do multiple bites at the same site to kind of dig in, or the tunnel through the tumor to get the deeper part to help your pathologist make the diagnosis.
Thank you very much, Dr.